Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning. Approximately 1 in 10 people have disorders of gut-brain interactions, or DGBI for short, formerly known as functional gastrointestinal disorders. And so today I've invited Dr. Mohsin Butt to discuss this topic with me. Dr. Butt is a gastroenterology trainee with a subspecialty interest in neurogastroenterology. He's funded by the National Institute of Health Research and is a committee member of the British Society of Gastroenterology in the Neurogastroenterology and Motility section, and is currently on a research sabbatical at the Mayo Clinic in the US. Welcome, Mohsin.
Thanks so much for having me, Sangeeta.
Thank you. So could you tell us what this term neurogastroenterology is?
Yeah, sure. As the word suggests, it involves the brain, i.e. neuro, and gastro being the gut. And it's the brain connects to the gut in a multitude of different ways, be it via nerves, hormones, the immune system. And it's a bidirectional link. So the gut communicates with the brain, and the brain then communicates with the gut. And I think the easiest way to conceptualize neurogastroenterology is if you think about if someone is very anxious before an exam, you get I get very stressed out, and you often experience symptoms in your gut. Some people get diarrhea, some people get constipation, and so that's a real world example of neurogastroenterology. And it's a growing field. It's a relatively small research field, but it accounts for a significant proportion of clinical cases that we experience that rather we manage in hospitals. It's a field that I'm very passionate about. I've been very grateful to have had lots of very good mentors in the field as well over the past few years.
Interesting. Thanks for sharing that. So you've written a module on this for MIMS Learning, and I was intrigued to learn that functional disorders of the gut are now termed disorders of gut-brain interactions. Could you talk a little bit about why the terms have changed?
Yeah, so the term functional was, historically speaking, that is a term that was reserved for conditions where people thought it was all in the head, right? That you have abdominal pain, there's no cause for the abdominal pain, so okay, it must all be in your head, it's a functional problem. Unfortunately, that sort of attitude has remained within mainstream discourse, and so that that propagates stigma. It means that patients are less likely to consult with their doctor if they have what was formerly known as a functional condition, and it also means that doctors may not treat patients' concerns as seriously as they should be. And so the Rome Foundation, which sets the diagnostic criteria for disorders of gut-brain interaction, have essentially now said, remove this term functional, and let's all say disorder of gut-brain interaction, or DGBI, as an antidote to that stigma. And that term DGBI also recognizes the very complex genesis of these conditions. Irritable bowel syndrome is not all in the head. There's a lot of evidence that it can be caused by alterations in the microbiome, alterations in nerve function within the gut, alterations in brain structure, etc. It's a term that respects the very complicated disease that is irritable bowel syndrome, or functional constipation, or functional dyspepsia.
That's true. How can GPs recognize disorders of gut-brain interaction in primary care?
I think we ought to focus on the statistically commonest disorders of gut-brain interaction. So let's say irritable bowel syndrome and functional dyspepsia. So briefly, irritable bowel syndrome is a abdominal pain disorder where patients have abdominal pain over a certain duration of time, and they have an alteration in bowel motion, in stool form, and the abdominal pain is associated with defecation. That is the criteria for diagnosing irritable bowel syndrome. Of course, in primary care, as all good GPs will do, they will look at red flags, rule out any red flag symptoms like weight loss, rectal bleeding, waking up at night to defecate, etc. And if a patient is in the correct demographic and they have appropriate risk factors, then it is possible to diagnose irritable bowel syndrome positively. So that means not by a process of exclusion. So in other words, that means it's possible to diagnose irritable bowel syndrome without an endoscopy, provided a patient meets the diagnostic criteria, and has the appropriate risk factors. A clinician should perform comprehensive clinical history. They need to do a proper physical examination, and where possible exclude the commonest organic conditions like celiac disease. And the same case goes for functional dyspepsia. So functional dyspepsia is just a fancy term to describe indigestion. It's a cluster of symptoms that affects the upper gastrointestinal tract. It's characterized by upper abdominal pain and feeling full up very quickly after eating a meal, and feeling very full up for a long time after eating a meal. So postprandial fullness and early satiety. Now, again, functional dyspepsia can be diagnosed positively in patients. You don't need, in select cases, you don't need to perform an endoscopy to diagnose it. If a patient responds appropriately to first line therapy for functional dyspepsia, which is proton pump inhibitors, then that reinforces the diagnosis that this is indeed functional dyspepsia.
I see. So you mentioned risk factors, and it makes me wonder whether some patients are at a higher risk of DGBI than others.
Yeah, sure. So the literature and the evidence shows that for irritable bowel syndrome, so it's bimodal distribution. Functional dyspepsia, from the top of my head, also has a similar distribution. Secondly, the evidence shows women are at increased risk of disorders of gut-brain interaction compared to men. The reasons for this are unknown right now, but a lot of people have postulated that it could be related to differences in hormones. And thirdly, another key risk factor for DGBI could be previous infection, for example. So post-infectious irritable bowel syndrome is where patients develop irritable bowel syndrome after having gastroenteritis. So that's another risk factor. But there are a multitude of different risk factors for DGBI.
Is there a genetic predisposition for DGBI?
Yeah, absolutely. There are a number of genetic markers that have been associated with all forms of DGBI. Genes have been implicated in the genesis and evolution of, I guess, every single disease in the world, right? And there's always going to be some paper somewhere that has demonstrated a link with one's genes. But when it comes to clinical practice, there is no role for genetic testing right now in irritable bowel syndrome, or rather for DGBI more broadly. But it's an exciting field because if we can identify a genetic marker, then possibly we can use targeted therapies and tailor therapies according to one's genotype, or rather to one's genes. So if a patient is expressing more of a certain gene, it's possible that they might be more receptive to a particular drug, or a drug at a particular dosage.
Seems like there's a lot of potential with targeted therapies for DGBI. Lately, we've been hearing a lot about how the microbiome is connected to the brain and how it influences disease pathogenesis and recovery. What would you say is the microbiome's role in the pathogenesis of DGBI?
The microbiome, again, as with all diseases under the sun, it has been implicated in the genesis of an evolution of a disease. And there have been a number of different alterations in microbial. So there have been a number of studies that have suggested that there are alterations in microbial diversity in patients who have DGBI vis those who don't have DGBI. And that has paved the way for research into fecal transplantation, where stools from a healthy participant are then inserted into the colon of someone who has a DGBI, and one then assesses whether their symptoms improve. And in addition to fecal transplantation, for example, there's also been a massive explosion in probiotics, prebiotics, postbiotics, and these are all agents that either increase the diversity, or rather, they either feed the microbiome, so they make your microbiome happier, or they are the byproducts of what the microbiome produces. like short chain fatty acids, for example, that the microbiome produces, which you can then eat instead, which are postbiotics. And again, the evidence for its use is pretty scanty. From the top of my knowledge, the American College of Gastroenterology, the British Society of Gastroenterology, and the Canadian Association of Gastroenterology do not recommend any single biotic for the management of DGBI right now. And from the top of my head, what the BSG guidelines have said is that if you are to use a probiotic, then use it for like 3 months. If you don't have symptom response within 3 months, then it's probably best that you change it. But you should wait at least 12 weeks in order to see some symptom improvement before you start changing.
That's interesting. You mentioned fecal transplantation, but am I right in thinking there aren't as many human trials investigating this?
To my knowledge, there have been some studies of some randomized controlled trials that have used fecal transplantation in the management of hepatic encephalopathy. But when it comes to DGBI, I'm not familiar with that literature.
I wasn't aware of that. Now, going back to the microbiome for just a minute, I want to ask, would it be possible to improve the prognosis of a DGBI by addressing how the microbiome influences the brain?
Yeah, so the microbiome can be manipulated by prebiotics, which feed the microbiome. Then you have probiotics, which are the actual bacteria that you can ingest, and then the postbiotics, which are the byproducts of what the microbiome produces, like the short chain fatty acids, which one can then consume. There is evidence that abdominal pain may improve with irritable bowel syndrome if one takes a particular strain of a particular bacteria. There is definitely a meta-analysis in Lancet Gastroenterology and Hepatology within the past 5 years that has shown particular strains of bacteria that might have some prognostic benefit in the management of irritable bowel syndrome. But again, there's no single agent that we can recommend right now, and and the guidelines don't recommend a single agent either right now. It's possible that bloating might improve. Again, it's possible that abdominal pain may improve with a particular strain of bacterium. It's possible that postprandial fullness may improve or early satiety may improve. But right now, I don't think it's possible for a recommendation to be made.
Yeah, the microbiome is so complex that it must be impossible to narrow in on a single species of microbe that will resolve all symptoms.
Exactly. There's no panacea right now. Absolutely.
That's true. I know you mentioned prebiotics, postbiotics, probiotics, and so on. But aside from all of these, what treatments are currently available for treating DGBI? And I know this is a really broad question given how many DGBIs are there. But speaking generally, what treatments would you say are currently available?
Yeah, sure. So I'll focus on the commonest DGBI. So I'm going on and on about irritable bowel syndrome and functional dyspepsia because those are the two commonest that one will encounter in primary care. There is good evidence for the role of neuromodulators like amitriptyline in the management of irritable bowel syndrome in primary care as a second line agent. So first line management for a condition like irritable bowel syndrome will be lifestyle changes, i.e., improving sleep, improving diet, working with a dietitian to identify trigger foods, and then possibly working with a dietitian to follow a low FODMAP diet, which is an exclusion reintroduction diet. And then following that, if that fails, patients may be eligible, provided they don't have any contraindications, to start low dose tricyclic antidepressant. So, an example of that would be amitriptyline. Now, I say antidepressant not because all patients with irritable bowel syndrome are depressed. It's because the amitriptyline works, the amitriptyline is thought to work on the nerves within the gut wall as opposed to the brain itself. Now, the reason I say that is because there was a very good trial published in the Lancet last year, the Atlantis trial, which was run in the UK by a group in Leeds. And that demonstrated that low dose amitriptyline reduced abdominal pain in patients with irritable bowel syndrome, These compared to patients with irritable bowel syndrome who were treated with a placebo drug. And interestingly, within the group that within the patients who responded to amitriptyline, their depression, the levels of psychological distress did not alter, but the levels of abdominal pain reduced. So that suggests that amitriptyline's effects are peripheral and not central. So in other words, they're not changing depression, they're not affecting anxiety levels, but rather they're affecting the way that the nerves within the gut function. That's what's been suggested. Neuromodulators like tricyclic antidepressants at a low dose are indeed have now been proven to be effective in the management of irritable bowel syndrome. From the top of my head, I'm not aware of any clinical trials that have assessed tricyclic antidepressant use in the management of functional dyspepsia, but to my knowledge, there are anecdotal data to suggest that tricyclic antidepressants also work in the management of functional dyspepsia as a second line agent.
Okay, interesting. Going back to the subject of GPs, what's one thing that you'd like most GPs to address when they encounter individuals with a DGBI?
Firstly, I'll say GPs will have a lot more experience than I will have in the management of patients who have DGBI. And so it's often me that's taking advice from the GPs because they see it a lot more than we will see. That's to start with. But if I was to advise a colleague about how to manage a DGBI, I would say listening. Listening is so important. It's very easy for a doctor to interrupt a patient within the first 2 minutes or the first 3 minutes, particularly when we're so time pressured in clinic. We want to get our checklist out and we want to start asking questions immediately. And I fall into that trap all the time. And sometimes I just have to shut my mouth. Well, not sometimes, I have to always shut my mouth. And I have to say, you know what? Speak for 5 minutes. I will listen. I will write my notes. Once you've spoken to me, then I will ask questions. So listening is the key thing. DGBIs have a massive, massive, massive effect on quality of life. I help in a tertiary care neurogastroenterology service in Nottingham with my very close mentor, Professor Corsetti. And I've also got some experience in the London neurogastroenterology service with another dear mentor of mine, Professor Aziz. I've been involved in the management of very, very complicated cases of irritable bowel, very complicated cases of DGBI. And they have such a profound effect on the way people operate. You see people who can't even go outside and to meet with their friends because they're scared that they'll go out and they'll experience fecal incontinence. They are locked up in their rooms. They can't even eat the foods that they enjoy. They have patients that I've encountered have such restricted diets. And a listening ear and being empathetic goes such a long way in this field. I've been privileged to work with some phenomenal people who take the time to listen, and I've learned so much from them, and I'm very grateful to them.
All right. So you mentioned your mentors. Would you like to talk about someone who's inspired you?
Oh, where do I? Oh, there's too many people. There's the two I have to name, and I know they won't even mind me naming them. Is Professor Aziz in London and Maura Corsetti in Nottingham. And for different reasons, but always because of their passion and their commitment for patient care. They are consummate physicians who are genuinely interested in research. They're genuinely interested in improving outcomes for patients, and they've instilled in me a strong desire to help people who have conditions that historically have been ignored by the establishment. We're on a mission to change practice, hopefully.
That's amazing. And finally, what was your most memorable case and what did you learn from it?
Because I'm a neurogastroenterology trainee, I don't have any patients that are under me, but I've been involved in the care of patients who are managed by my bosses. And one patient case that strikes out to me was the case of a patient who had cyclical vomiting syndrome. I'll very briefly describe what cyclical vomiting syndrome is. So it's a disorder of gut-brain interaction which is characterized by stereotypical episodes of nausea and vomiting. What I mean by stereotypical is that they have a very particular start and end. So there's a prodrome phase, there's an emetic phase, there's a recovery phase, and then there's a stable phase. I'm not going to go into the nuances of those 4 phases. I would recommend that the interested reader go and read the gastroduodenal disorders paper published in Gastroenterology in 2016 by Stangolini if they're interested. But anyway, this is a patient who had cyclical vomiting syndrome and absolutely debilitated. She would have these episodes of nausea and vomiting once a month near the time of her period. She was just at home. She had no idea what was going on. And she was on a very high dose opioid. She was on 200 milligram of oxynorm a day. And as we know from Netflix and things, that has publicized the opioid epidemic, the opioid pandemic across the world. And opioids, we thought, were driving a lot of her symptoms. So my boss reduced the opiate dose and also started her on a low dose tricyclic antidepressant. As we've already discussed, has a role to play in the management of DGBI, like irritable bowel syndrome and functional dyspepsia. And so reducing that opioid, starting that tricyclic antidepressant, allowed her to enter clinical remission. What clinical remission, I mean the absence of any episodes for at least 6 months. And her quality of life was improved so significantly. Her weight improved. It was such a dramatic increase in her weight. Her weight improved by at least 1/3 from what I can remember. Her family just looked so happy, and she was so grateful. And I don't know, these sorts of stories, to me, they make it all worthwhile, that at least one person was helped by what we did, and that's very rewarding.
That's really interesting. Thank you so much for sharing that, Mohsin.
Thank you.
And thanks for listening. You can check out the MIMS Learning module on disorders of gut brain interaction, co authored by Dr. Mohsin Butt, Professor Qasim Aziz, and Professor Maura Corsetti, for a detailed description of some of the common DGBI and their diagnosis and management. Do join us next time for a studio discussion on chronic pain. See you then.